So good morning. I hope everyone's doing well out there. So I will be lecturing the central nervous system portion of the pharmacology lectures. It's divided into a couple parts, so we'll be doing 2 lectures on this. And what we will be doing to start off with is doing a quick little review of the nervous system, just to kind of help create a context for what the various targets will be when we're describing how we use drugs to interact with the nervous system. The main conditions we're going to be treating will be certain things like sleep, anxiety, depression. We're also going to be talking a little bit about schizophrenia and other psychotic conditions in the second lecture. So the last time I checked the NPLEX requirements, and it may have changed because I haven't checked it for this year, these are a list of the various drugs that are going to come up in the following lectures, or also some of these may have appeared in the ANS lecture. So that's just a little list of some of them that you can look at on your own. I think today the main drugs we're going to try to cover is, after doing a little review, we're going to talk about local anesthetics. We'll talk about sedative herbs used for sleep. We'll discuss in passing a little bit about some of the neurotoxins, both herbal and other natural sources, and then get into some of the anti-epileptic drugs. Some of the slides I'm going to quickly go over. You may not need to know them for the exam. I do include some natural treatments, some herbs, maybe some vitamins and minerals, for the context of helping you understand how it all sort of fits together. Whether or not you need to know it for the exam, Dr. Lake will probably let you know. But I think just for your general understanding of how the nervous system works, it's good to understand how everything kind of fits together. So that's why I've included them. Now, a quick little review. We'll begin with the neurotransmitters. And the nervous system is very, very complicated, and I'm going to give you a quick little overview, sort of the Coles Notes version, or a very simplified version of understanding the nervous system. If you've done your undergraduate in the nervous system of neuroendocrinology or one of those types of topics, this will probably be very, very basic, but I find that in order to understand how the drugs work, it's useful to have a quick little basic understanding of how these various neurotransmitters work. When you look at the neurotransmitters, typically I divide them into a couple different categories. Serotonin and melatonin are structurally related. They're derived from tryptophan. The catecholamines have a similar structure. They're derived from tyrosine. Acetylcholine, it's sort of, we've already discussed it, it's sort of unique. GABA and glutamate also have sort of unique structures that are derived from amino acids. So most of these guys up here, the precursors are going to be some type of amino acid. When you look at the function of other neurotransmitters, we're not going to talk about histamine very much, but its main function in the body is that it's involved with being awake, also with equilibrium. It has a function also when it comes to allergies. Acetylcholine, as you know, it's the main neurotransmitter of the parasympathetic nervous system. But in the central nervous system, it also plays an important role in consciousness, your motor coordination. Is not the main neurotransmitter, but it does play some role, and also in cognition and forming new memories. So it does have some important roles in some of the diseases like Alzheimer's and dementia. When it comes to norepinephrine and epinephrine, in the central nervous system, it plays an important role in mood, appetite, also to concentration to some degree. Dopamine, it's going to have its main role involved with movement. So conditions like Parkinson's disease, there's a deficiency of dopamine. But it also plays a role in behavior, so it does have some effect on depression and mood disorders. And it's the main neurotransmitter that's released when people are becoming addicted to something, whether it's cigarettes or cocaine or gambling or whatever it is that's involved in that process. And there is some benefits for cognition and focus. Serotonin, its main role is going to be involved with mood, and it's a target for a lot of antidepressant drugs, but it also plays a role when it comes to appetite for regulating heat in the body. There are some effects that can cause hallucinations in high amounts as well. GABA, it's the main inhibitory neurotransmitter in the body, so it has a calming effect. GABA is the main inhibitory neurotransmitter in the central nervous system. Glycine also has an inhibitory effect, primarily in the spinal cord. And then glutamate plays a few roles, but one of the roles is that it acts as an excitatory neurotransmitter. So when you look at the nervous system, a quick little review here, you have nerves that maintain a resting membrane potential at a certain level, and when it becomes increasingly more positively charged on the inside, then you basically get nerve conduction that occurs, and that little electrical impulse that travels down through the nerve causes vesicles containing neurotransmitters to spill out these neurotransmitters into the synaptic junction, and then these neurotransmitters will bind to various receptors in the body to have some desired effect. And then eventually they're broken down. So that's a quick little overview. I'll do this in a little bit more detail now. So here's a diagram of our nerve, and if you look, there's generally more negatively charged ions on the inside, so in this case it's chlorine ions, and that gives you a resting membrane potential of about greater than negative 30 millivolts. And so because it's more negative on the inside than it is positive, that's what gives you that membrane potential. And what's interesting about cells is they maintain this by allowing more negative ions to flow in to hyperpolarize or to make it harder for those nerves to fire. So that means you're going to have a sedative effect. Or you allow sodium ions or other positively charged ions to flow in, making it more positive, and that destabilizes it. Now, in the case here, in the upper right-hand corner, you've got that green little channel. That is a ligand-gated ion channel. A ligand is just it's like a chemical that binds, it's like a substrate that binds to a receptor. So that's what it means. So basically some drug or some other neurotransmitter binds to this little receptor. It allows the channel to open up, and naturally the sodium, or it could be also calcium ions, would flow into the cell, and that will cause the membrane potential to become depolarized. So you're basically making it less negative. And what happens is once you hit a membrane potential of roughly negative 670 millivolts, what will happen is there are other voltage-gated ion channels. So these are like a little battery meters that detect the change in the voltage within the inside and the outside of the cell. And when it hits about negative 70, they automatically open up. So rather requiring a chemical to bind to them, they pick up on the electrical impulse. And so when they open up, they quickly allow for the influx of cations or positively charged ions. And as a result, you'll get nerve conduction flowing down the nerve. And when they reach the bottom, this nerve conduction will cause the vesicles that store the neurotransmitters to sort of migrate to the edge of the cell, and then they will basically spill out into the synaptic junction and bind to the receptors on some target organ or target cell. And this may have some effect. It may cause the nerve to fire, it may cause salivary glands to start excreting saliva, may cause muscles to fire, whatever it may be. Now, after the neurotransmitters are out, you can't leave them floating around forever, otherwise they'll constantly stimulate the various receptors. And so you want to basically store them back up. And so what happens is there are transporters that are called reuptake transporters that will pull the neurotransmitters back into the cell so that they can then migrate into storage vesicles. And there are vesicular monoamine transporters that will take these neurotransmitters and transport them inside these vesicles so they can be stored for later use again. Now, there's always a balance going on where if the neurotransmitters are left floating around outside or inside the cell and they're not within a vesicle, then various enzymes can be used to inactivate this to help control that. So there are several different enzymes that are used as neurotransmitter inhibitors or used to break down neurotransmitters, and those would be the monoamine oxidase enzymes, the catechol methyltransferase enzymes, and also the acetylcholinesterase enzymes. And so each of those targets different neurotransmitters, and their primary function is to inhibit these things. Because if you didn't have them, then there'd be the risk of you constantly being stimulated by various neurotransmitters, or also neurologically active things in our diet that we'll talk about later on. So when it comes to the inactivation of the neurotransmitters, we're going to go into a little bit more detail on what those enzymes we just described target. So the first one is monoamine oxidase. This enzyme is throughout the body. You'll find it also in the gut, and it's designed to help break down neurologically active, psychoactive compounds in our diet. It's also found in the liver and in the central nervous system. Its primary function is to break down various monoamine neurotransmitters. So monoamine just means that it has a single amine group on it. And if you look at the picture of the serotonin in the upper right-hand corner, the amine group is the NH2 group on there. And so you will find amine groups on serotonin, melatonin, epinephrine, norepinephrine, and dopamine. So almost all the neurotransmitters will be affected by this. Now, for interest's sake, vitamin B6 is a cofactor for this enzyme, and so it's just one of the roles that vitamin B6 has, and certainly deficiencies can occur in people and can upset the nervous system. Another important enzyme is called catechol methyltransferase enzyme, or COMT. Now, this enzyme is more selective, and it targets specifically the catecholamines. A catecholamine is, if you look at the structure of norepinephrine in the upper right, you've got that pink ring structure that I've drawn there. The catechol group is when you have two OH groups side by side, and that's what a catechol group is. It's a type of phenol group. And so dopamine, norepinephrine, and epinephrine all have this structure. Serotonin and melatonin do not have the structure, as well as neither does the histamine or acetylcholine. Last week we talked about ephedrine. Ephedrine does not have this structure as well. It's not a catecholamine, so it's not targeted by this enzyme, or not inhibited by this enzyme. So what this specifically does in the body is it adds a methyl group to the OH group, or to one of the catechol groups on these neurotransmitters, and that inactivates it. It prevents it from binding to the receptors to have the desired effect. So the primary cofactor for this is S-adenosylmethionine. Now, you may have heard of this before. It's available as a natural supplement. Research shows that it may have benefit for treating conditions like depression. And I'm not quite sure what the precisely how it works, but it does have an effect on these catechol methyltransferase enzymes. Just as a side, when I was in my final year of university, my project for my thesis was to create drug analogs of S-adenosylmethionine in hopes of developing an inhibitor for the catechol methyltransferase enzyme, because if you can inhibit this enzyme, it could have potential for treating conditions like Parkinson's, where there's a deficiency of dopamine. So if you can inhibit the breakdown of dopamine, you might be able to elevate it in the central nervous system and have a positive effect. So I spent like a year making these in a lab. So when it comes to something like norepinephrine, dopamine, epinephrine, they can be inhibited by either the catechol methyltransferase enzyme or the monoamine oxidase enzyme. Now, when it comes to serotonin, it's not affected by the catechol methyltransferase enzyme, so it only is affected by the one. Another enzyme that's important to mention is the acetylcholinesterase or cholinesterase enzyme. Now, Acetylcholine, as I mentioned before, it's the main neurotransmitter of the parasympathetic nervous system, but it also plays a role in the central nervous system when it comes to it's a secondary target for conditions like Parkinson's and also Alzheimer's. It's not a primary drug, but a primary target for drugs, but it does have effects on movement and cognition. And we'll discuss it a little bit later on, probably in the second lecture. So that's a quick little review of the various neurotransmitters involved with the central nervous system. Now what we're going to talk about is how drugs could target these neurotransmitters. And the main goal of drugs is we want to maybe elevate the neurotransmitters or break down the neurotransmitters or target the receptors that they're binding to have various effects on it. So here are a number of places I think drugs can target. Now, if you look at 1A in the upper right, that red nerve that's connected to the blue nerve in the middle, that's an inhibitory nerve or could be an excitatory nerve. So you could target that and prevent the release of neurotransmitters from that nerve, and that would have some sort of effect. You could also target the ligand-gated ion channels, and so those are the channels that some neurotransmitter or drug can bind to. Or you could target maybe the voltage-gated ion channels. So these will both affect the polarization or depolarization of the nerve. There are various drugs we're going to talk about shortly that interact with that. You could also develop a drug that binds specifically to the receptors that the neurotransmitters bind to. So you're not directly affecting the neurotransmitters that naturally occur in the body, but rather you're binding to the receptors. So an example of this would be maybe some kind of sympathomimetic that binds to the adrenergic receptors to stimulate it. And we've already discussed those shortly. Or it might be some drug that targets the receptor instead of turning it on, it blocks it, and that would be an antagonist. And so something like an anticholinergic drug that we described last week would be an example of a drug that would do that. You could also target the enzymes that we just discussed that are involved with breaking down neurotransmitters. So if you were to inhibit monoamine oxidase enzyme or the catecholmethyltransferase enzyme, you would elevate those corresponding neurotransmitters in the body to have some desired effects. So they could be used in things like depression, would be an example. Another thing that you can do is, as we mentioned before, once the neurotransmitters spill out of the nerve, they need to be taken back up. And so there's two ways that you can affect that. I'm going to jump to number 6 first, is you can prevent the reuptake of the neurotransmitters back into the cell, and targets for that drug would be certain antidepressants. So if you don't take them back into the drug, if you don't take them back into the cell and store them, then they're now available to interact with the receptors longer and have that positive effect. So things like selective serotonin reuptake inhibitors target the transporters that bring the neurotransmitters back into the cell, and as a result, for example, serotonin interacts with the serotonin receptors more and makes you feel happier. So that's the theory. And finally, if you don't store the neurotransmitters, what happens is they're now available to be acted on by the enzymes like the catecholmethyltransferase or monoamine enzymes. And so as a result, if you prevent the storage, then you increase the breakdown, and that depletes those neurotransmitters. And so depending on the type of condition, you may want to increase or decrease a particular neurotransmitter. These are the various ways, or the effects of those neurotransmitters, and these are the various ways that we can do that. We're going to talk about drugs that interact with every single one of these, targets one of these enzymes, either this lecture or the next one. Now, another little review is we're going to talk about, there are a couple different, there's the main inhibitory and excitatory nerves and neurotransmitters in the central nervous system. What we're going to do is we're going to go through and discuss the background on what these are, and then we'll talk about a quick drugs and also herbal substances that can target these. So the main inhibitory neurotransmitter in the central nervous system is going to be related to GABA is the main neurotransmitter, and there's receptors for the GABA and also benzodiazepine receptors, and these are coupled. We'll talk about that in a little bit more detail. The main inhibitory neurotransmitter in the spine is glycine, and so both GABA and glycine cause the nerves to become more hyperpolarized, and as a result, it makes it harder for them to discharge. Now, one of the main excitatory neurotransmitters in the body is glutamate, and it causes cells to depolarize. Now, also the voltage-gated ion channels, they are affected primarily when the when the glutamate receptors or one of the other excitatory neurotransmitters cause the cells to discharge and depolarize. Then they open up, and they can also be a target as well. So if you prevent them from opening up, or you keep them open, it'll have an effect on the body. So inhibitory neurotransmitters on the right, excitatory transmitter on the left. Glutamate's just a general one. Other things like when you think about serotonin, dopamine, epinephrine, those are all have an excitatory effect on the body by interacting with the receptors. Now, the inhibitory nerves. So when you've got GABA, GABA is it's derived from an amino acid, and it's the main inhibitory neurotransmitter in central nervous system. And what happens is that it has a receptor that it binds to, and when it binds to it, it allows for the influx of chlorine ions, which are a negative ion, and so they make the inside of the nerves more negatively charged. And as a result, it makes it harder for those cells to basically depolarize. So it basically helps to dampen the nervous system, makes it harder for the nerves to fire. And in case you're wondering, glutamic acid, also referred to as glutamate. Now, this is interesting because it's actually used as an excitatory neurotransmitter, but in the body, in the presence of vitamin B6 and the glutamic acid decarboxylase enzyme, that forms your GABA. And so here's another place. We've already mentioned vitamin B6 was involved already back. I'm just going to skip over there. In the monoamine oxidase enzyme there, showing on the right-hand side. So the other enzyme that's involved with is forming GABA. So vitamin B6, sometimes you'll see women who are on the birth control pill, which depletes vitamin B6. Often they may suffer from a little bit of anxiety and depression, and maybe it's because of the effects that it's having on the neurotransmitters, in particular the GABA in the system. Now, GABA is also inhibited by an enzyme called GABA transaminase. Now, this enzyme is similar to, for example, the monoamine oxidase enzyme or the catechol-methyltransferase enzyme. So it's involved with the breakdown. I probably should have mentioned it over there. So this is a quick little overview of how GABA is made and broken down in the body. Now, what happens on a cellular level is here we've got the GABA receptor bound to the transporter there, and when GABA binds to its receptor, that transporter will open up, allowing for the chlorine ions to go in, and that causes the cell to become more depolarized. Now, in addition to the GABA receptor, right next to it, it's coupled with the benzodiazepine receptor. And so what's interesting is the benzodiazepine receptor, it requires GABA to be bound to its receptor for it to have this effect. But what it does is it acts to enhance the inhibitory effect of GABA. And this is a target for a lot of the drugs involved with sedatives for sleep, certain anticonvulsants, some anxiolytic drugs to decrease anxiety, and also some muscle relaxants. And so here, going back to this image, the GABA is bound to its GABA receptor, allowing some chlorine to travel in. And then when some kind of benzodiazepine drug or something that targets that receptor binds to that receptor, it allows the transporter to open up even more, allowing for a greater influx of chlorine ions into the cell, therefore depolarizing it more. So if you think of a drug that interacts with this, it's going to make people feel really calm, maybe a bit sluggish, maybe sleepy. It might even knock them unconscious because you're inhibiting, having such a great inhibitory effect on the nervous system. So the GABAergic drugs, the main classes, and we're going to go into this in more detail later, but the main classes of drugs that have some sort of effect either on GABA or benzodiazepine receptors are going to be the drugs called the benzodiazepines, and this would be, for example, Valium. It might be certain drugs that are called Z drugs. These are sleep aids. Barbiturates, which are not used as much as they used to be, but they're heavy, strong sedatives. Also, certain drugs that are newer GABAergic drugs that have kind of come out of the market in the last couple decades and are used more for, some of these might be used as anti-epileptic drugs, so people with seizures might take these drugs. And so the main targets would be they're sedatives, they're anxiolytics, they're muscle relaxants, and they help with epilepsy. The main condition is going to be sleep, anxiety, seizures, and even conditions like bipolar, like manic depressants. Now, you might not need to know this for the exam, but I think it's fun to know this for your sake. When you look at the GABA system, there are a number of herbs that interact with the GABA system to have a sedative effect. So a lot of the nervines or herbal sedatives will target the GABA system. And they may do this through a number of different mechanisms. Not all of them have been researched thoroughly and do we fully understand what the mechanism of action is, but we can appreciate that most of these have some sort of interaction with it. Valerian is one of the more studied ones, but so is kava, passionflower, skullcap, chamomile, vervain. Most of these will have some mild little effect there. And the way that they can affect the GABA system is either they bind directly to the GABA receptor, or they bind to the benzodiazepine receptor, acting as an agonist in both cases, or they may target the glutamic acid decarboxylase, the GAD enzyme, which is involved in the synthesis of GABA, and so they may upregulate the enzymes involved with that, or they may inhibit GABA transaminase, which is by inhibiting the breakdown of GABA, you could elevate the levels. Now, valerian, in addition to working on the GABA system, does modulate serotonin receptors and also something called adenosine receptors. If you remember, the adenosine receptors is the receptor that coffee or caffeine binds to, and acts as an antagonist to those receptors to have a stimulatory effect. So GABA has a sedative effect by binding to those receptors and acting as an agonist. So adenosine receptors are a newer group of receptors that are being explored for potential for drugs. But if you're drinking coffee, you're blocking them, and if you're taking valerian, then you're going to be stimulating them and having that nice calming effect. So on the right is a picture of skullcap. This is Scutellaria lateriflora. This is one that grows in North America. Chinese skullcap also has some sedative effects. Here's passionflower on the right, a nice herb that's often used in herbal teas or in tinctures to help with sleep. Amanita muscaria, remember we mentioned this already when we're describing muscarinic receptors. In addition to the effects that it has on the parasympathetic nervous system, it has a GABA agonist. It has a compound that binds to certain GABA receptors in the body, and so it has a strong sedative effect, but it also has a mildly hallucinogenic effect because it can kind of promote lucid dreaming. So in shamans in Siberia, they would use this to help promote lucid dreaming and have a psychotropic effect. This is a different mechanism altogether from when people take magic mushrooms, which is an effect it might have on serotonin receptors. And there are safety concerns with doing this because of the strong effects it has on the parasympathetic nervous system, causing nausea, vomiting, and diarrhea. So don't mess with it, but just be aware that that's the mechanism for why this. Normally you see it in the Alice in Wonderland with the red cap with the white spots, and it sort of is associated with fairy tales and mysticism, and that's one of the reasons, because it binds to GABA receptors. So that's an effect in addition to the effects it has on the parasympathetic nervous system. So here's a quick slide that outlines the effects that valerian has. We know it stimulates the production of GABA in the presence of a cofactor like vitamin B6. We also know it binds the GABA receptors. We know that passion flower and skullcap have flavonoids that interact with the benzodiazepine receptor in the body and has a mild agonist effect for those. And then we also know that lemon balm contains rosmarinic acid, which is also found in things like rosemary and other members of the mint family. So I wouldn't be surprised if skullcap has it as well. And it's involved with inhibiting the breakdown of GABA. So lots of different places where the GABA system can be targeted to elevate the amounts of GABA in the body. Now, just for fun, I've shown a picture of, for example, on the left-hand side, there's the structure of diazepam. So this is one of the benzodiazepine compounds. And if you look at the structure of it, and then you look at two of the bioflavonoids that you find in passion flower and skullcap, the structures are similar. And you could see how these could be interacting with the same receptors and having some sort of effect there. And so I think that's just kind of neat to look at. And then if you look on the right-hand side, there's a neurotransmitter GABA. And if you look at valerianic acid that's found in valerian, if you look at the top portion of it, it has a structure that's not unlike GABA. And that bottom portion looks a lot like where you have the pentagon and the hexagon there, structures stuck together. That looks an awful lot like adenosine. So I don't know if valerianic acid interacts with some kind of GABA receptor, or if it's interacting, or if that same structure also interacts with the adenosine receptors. But either way, it has a calming effect in the body. So that is a couple examples of drug classes and herbs that interact with GABA to act as an agonist, to have a calming effect. Now, there's a GABA antagonist I want to discuss, and that's thuone. Now, thuone is the main essential oil that's found in wormwood, and you can also find it in cedar, various species of thuya, and I think that's how they developed the name. You also find it in garden sage, and it's found in lower amounts in other members of the mint family, and in essential oils. It's a monoterpene, like the ones we described last year, that has a stimulatory effect on the nervous system. And the way that it does that is it binds to the GABA receptor, and it acts as an antagonist for it, preventing the binding of GABA. And as a result, it decreases the action potential and makes the nerves kind of fire, makes it easier for the nerves to fire. So one of the side effects, for example, of drinking high amounts of absinthe is that the thuone acts as a neurotoxin. So it overstimulates the nervous system. And a small dosage, you might just get a mild headache from it. But as you increase the dose, so if you're taking a lot of these essential oils, let's say in a purified form, or you're drinking high amounts of absinthe, then you might start getting muscle cramps occurring, and an acute overdose situation, someone might go into seizures and have because the muscles are contracting too and firing too strong, and it could also cause death. So this is one of the reasons why, for example, absinthe, which is made from Artemisia absinthium, when you buy it in North America, they limit or they remove the thuone content from it so that you don't have this toxin in there. Obviously, if you're making tinctures that contain sage, wormwood, cedar, there will be some thuone in it. So you would want to be careful giving these to people who have a history of epilepsy or people who have any kind of seizure issues. This is also something that's contraindicated during pregnancy. So any herbs that have that, I would just stay clear of. Again, it's going to be dose dependent, but best to avoid it if you can. So on the right is an image of what wormwood Artemisia absinthium looks like. Here's what the common cedar looks like that grows in this area. There's an image of sage. And there you go. So we've talked about the benzodiazepine receptors. We've discussed the agonists that stimulate those receptors and have a calming effect. And we've discussed the antagonists that inhibit those receptors and have a stimulatory effect. Now we're going to talk about the glycine receptors. And these receptors are primarily in the spine and in the spinal cord. And when it comes to glycine receptors, it has a similar role that GABA has in the body. It binds to its receptor, it allows for an influx of negative charged ions like chlorine, and this hyperpolarizes it, making the cells difficult to fire. And as a result, the overall effects on the nervous system, it kind of just dulls it down and calms it down a bit. Now, just as an aside, another agonist for these receptors is taurine. And taurine it's not an amino acid per se, but it's a derivative of cysteine. And so when cysteine, which is another sulfur-containing amino acid, is highly oxidized and goes through a number of different reactions, it forms taurine. And the taurine molecule, you will find this as a natural supplement. It's also found in things like Red Bull, and I should maybe mention brand names, but these energy drinks will often have taurine in it. And I suspect it might be used to help to offset some of the negative effects of the high amounts of caffeine that's in it. So it has a bit of a sedative effect to counteract the jitters that people get from having high amounts of caffeine. Taurine may have a blood pressure lowering effect. It may help to with anxiety, may help with muscle contractions. But that's just as a side note. So as a natural supplement, you can buy taurine or glycine. Now, those are both agonists. Now, an antagonist of glycine is something called strychnine. And the reason why I'm bringing this up is that you've probably heard of nux vomica. And nux vomica is often used as a homeopathic remedy for people that are type A personality, high energy, aggressive, irritable, very excitable. And it's made from the plant called Strychnos nux vomica, which is a nut that grows in, I believe, somewhere in Southeast Asia, India area, South Asia, India area. And it has been used historically in small amounts in herbal medicine, but it's pretty toxic, and it is a significant poison. And one of the ways that it works is it inhibits glycine receptors. So if you think about it, if you're inhibiting the glycine receptors, then you're no longer having that calming-like effect from it. And as a result, you have a very similar picture that you might get with conditions like from Thuyon. So this is not unlike Thuyon, where in general have a stimulatory effect. In higher amounts, it'll cause muscles to start twitching and contracting uncontrollably, and it can lead to basically convulsions and death. Now, this is what happens when people have an overdose of strychnos and also tetanus. Okay, and the reason why is that both tetanus and strychnine have a similar effect in the body. And what happens here is because the back muscles and the biceps are stronger than the triceps and the abdominal muscles, people who take an overdose will kind of take on this sort of form. Now, for fun, when you look at pop culture, for example, the Joker, who has this sinister-looking smile on his face, if you ever read the comic books, he often would use strychnine as a poison, because what happened is it would leave this mark on the person's face. When they died, they'd have this big, sinister-looking smile on their face, because it would cause certain muscles or all the muscles in the face to contract, but it would pull the face into this big smile. And sort of a demonic-looking smile is what's called rhizus sardonicus. And so it's sort of it's like was the trademark of the Joker when they found victims that had this smile on it, which is just kind of fun to add in. In addition, strychnine, it's often used as a poison in murder mysteries and in various movies and TV shows and novels and stuff like that. So you'll probably hear about it again if you keep your ears open for it. Now, as I mentioned before, what's interesting, just as a side note, is strychnine binds to the glycine receptors to act as an antagonist. And so tetanus toxin, when you hear about stepping on a rusty nail and you could get tetanus, tetanus has a similar effect on the body that strychnine does. And rather than binding directly to the glycine receptors and blocking it, tetanus inhibits the release of glycine from the inhibitory neurotransmitter. So if you inhibit the release of glycine, that basically means there's no glycine to have that calming effect. And so you get the same presentation of symptoms with an overdose or when people are subjected to this toxin, where you have that arching of the back and contractions of the arms. So we've talked about two inhibitory neurotransmitters, GABA and glycine, and also the benzodiazepine receptors. We're also going to talk about the excitatory nerves. Glutamate is one. It plays many different roles in the body and is also involved in memory, cognition, concentration, lots of different things. But in general, I would say glutamate and also aspartate, they bind to various ion-gated or ligand-gated ion channels in the body to have a stimulatory effect. Now, just as an aside, if you look at the bottom there, there's a glutamate receptor, and it also has glycine binding to it as a on a co-receptor there. And so it's kind of interesting that here glycine's playing sort of a secondary support as a excitatory neurotransmitter, even though its primary role is as an inhibitory one. So I don't know enough about that to comment on it. But what happens when the glycine binds to a receptor? It will allow calcium channels to flow into the nerve, and that will cause depolarization of the cell, make it easier for them to fire. So here you go, you've got the positive ions. So calcium would be one example. Potassium is another cation that can cause the nerves to depolarize. So when it comes to glutamate receptors, these glutamate receptors are often referred to as NMDA receptors. And so substances that bind to these receptors will have an excitatory effect. And things that block this can have sort of a calming effect. And so some examples is alcohol has many functions in the body, but one of the things that it does is it can bind to the inside of the channels and inhibit the actions of this. Barbiturate drugs that are strong sedatives have multiple effects in the body, just like alcohol, and one of them can be as it acts as an antagonist to these receptors. And certain dissociative hallucinogens like PCP, ketamine, laughing gas can also inhibit the firing of these receptors. So the clinical benefits or clinical significance is if you targeted these, you could improve cognition. So it might be used as for Alzheimer's. If you block them, you could have a sedative effect or an analgesic effect. Other conditions where there's excessive firing of the nerves, in the case of tinnitus, where you get constant ringing of the ears, or epilepsy where the nerves are firing too much, you might target glutamate receptors for helping with these conditions. So a couple ways that the drugs can work is they could bind directly to the glutamate receptor, or they may interfere with the channels themselves and sort of go inside the channels and act as non-competitive or uncompetitive channel blockers for this. So this is where you get some of the dissociative drugs, alcohol, barbiturates. They don't bind to the glutamate receptors, but they kind of get stuck in the transporter themselves and then prevent the calcium from flowing in. So a class of drugs, we won't talk a lot about them, but a class of drugs that we can mention quickly are the dissociative drugs. And dissociative drugs include things like Special K. You may have heard of it. It's a ketamine. It's a horse tranquilizer. Also, phenylcyclidine is a PCP or angel dust. And I would say probably laughing gas, which is the most benign of the three, is also considered a dissociative hallucinogen. Just as an aside, sometimes Special K and angel dust or PCP have been used recreationally as a drug for people. You generally don't see this very often or hear about it. I remember when I traveled in India, a lot of people, you can get pretty much anything over the counter without a prescription in India. So sometimes I bumped into one guy who was taking a lot of ketamine, and it's used as a horse tranquilizer and a strong sedative, not a very safe thing to do. Don't think that's a very wise thing, but anyways, I don't know why he was taking it, but I guess some people like the fact that it has this nice numbing or calming effect. PCP, you always heard about when I grew up in the 80s, there's angel dust or PCP always sounded really like a weird drug for people to take. and probably most people have had laughing gas before if they visit the dentist. Um, my dentist never actually used laughing gas. All my friends, doctors, used nitrous oxide. Um, and I always was kind of envious. And I remember once when I was in university, I was at McGill University, and I went to a party that the dental students were having, and I went into a room and it was full of these balloons, which I thought was odd, and they were all full of laughing gas. So I've only tried it once, and that was at a party at McGill. I don't really know how they got their hands on a canister of laughing gas, but all I remember doing it, and I tried it just really quickly, was everything just got really slow and dumb, and you kind of get an expression like you're really feeling slow and stupid, and everything seems funny. And I guess under the influence, I guess if somebody was removing a tooth or cutting open your jaw, it would just seem really silly and humorous because you can't really feel your body. You're disconnected from it. And that's why they call them dissociative hallucinogens, where you can observe and you can sense what's going on, but you seem totally remove your mind from your physical body, which is probably good under those circumstances. But and I guess people who are going through a lot of suffering may abuse these things. So the way that these drugs work is they primarily block the NMDA receptors in the body, and they kind of make you feel dissociated or separate from your physical body. They do have this generalized sedative effect, but they do distort reality and sensations a little bit and cause some hallucinations or just sort of at least an altered perspective. What else? I have read about there was a couple really where people took an excess of PCP or ketamine that they did some weird things, and there was a couple of murders that were associated with people overdosing or doing high amounts of PCP, and it was reported in I think in the 80s. And so it's not really a fun recreational drug for people. So it's not really something that you hear a lot of people doing. Ketamine was used way back in medicine, but because of safety concerns, they no longer use it in medicine. But it is still used in veterinary medicine. Now, on the topic of that, dextromethorphan is a cough suppressant, and you may have heard of people abusing cough medication to get high. And one of the reasons why is that dextromethorphan, it does suppress a cough because it works by a few different mechanisms. It targets opioid receptors and nicotinic receptors in the body to have a cough suppressant-like effect. It has a mild sedative effect, but it also acts as an agonist for NMDA receptors and specific serotonin receptors in the body, so it can have a very calming, intoxicating-like effect. So not exactly the same as ketamine or PCP or laughing gas, but there is perhaps some overlap in its effects that it might have if you take high dosage. Certainly kids can act a little loopy when you give them cough medication. So although it's not classified as a narcotic, I don't think it is anyways. It does have some overlap, so there is potential for abuse with this. So now we're going to talk about sedatives and hypnotics. This class of drugs are primarily used to help as a sleep aid and also to decrease anxiety and possibly to help with muscle convulsions acutely. So when it comes to the sedatives, there's a few different classes that are used. A little background, hypnos was the Greek god for sleep. So hypnotic is something that's used to help induce sleep. A sedative just has a general calming effect on the body. And so if you think about it, a lot of herbs will act as mild sedatives. There isn't really a herb that will act as a true hypnotic or as a strong sedative. But certain drugs, if you take enough of them, whether you want to stay awake or not, you won't be able to. And that's what's related to these sedatives and the hypnotics that we're going to talk about. So when it comes to insomnia, a lot of people will experience difficulties falling asleep and staying asleep at some point in their lives. There are several classes of drugs that can be used to help improve sleep quality. Now, from a natural standpoint, you always want to help the person deal with stress. You want to get them exercising more. making sure that they're not reading their iPad before they, while they're laying in bed or playing video games in bed, because that blue light and white light from the electronic devices will suppress melatonin levels. Even small things like if you're going to have an alarm clock in the room, get one that has a red display light rather than the blue display light, because the red will not have an effect on melatonin, but the blue light will. Making sure there's no light coming into the room. Those are a few things. Now, in addition to doing all those proper sleep hygiene measures, you may have people taking drugs for insomnia, and it's worth understanding how these drugs work. And the main prescription drugs that are being used right now are Z drugs, and we'll talk about them in a second. Benzodiazepines were used more historically, but because of potential for abuse and they're a little bit more potent than the Z drugs, even though they have the same mechanism, Z drugs are used more today. Now, occasionally people are given other types of drugs, and we'll talk about these in general later on. These are drugs that are like serotonin antagonists and reuptake inhibitors. Trazodone is not used as a primary first-line drug. It's often used as a secondary. Other antidepressants we'll talk about later on, like tricyclic antidepressants. In addition to working on serotonin, they do have some effects on histamine, so they can have a calming effect. Longer-acting benzodiazepines can also have an effect, but there are greater side effects. So those are all the prescription ones. The non-prescription ones are related to, for example, melatonin. Melatonin is recognized as being something that can help to initiate sleep. And then antihistamines that are available over the counter, like Nitol, Benadryl, Sleep Ease, those all contain a substance called diphenhydramine, and that can help with sleep. But I'll talk about that in its own little section. So to begin with, benzodiazepines. These are the primary drugs used as sedatives and hypnotics. I just like this little picture. Sweet, refreshing Valium, when denial is the best alternative. Now, back in the 50s and 60s, often housewives were prescribed Valium or other benzodiazepines. They may have been given barbiturates in the past as well. And you may have heard of the Rolling Stones have a song called Mother's Little Helper. And this refers to sort of a story about mothers who were having troubles coping with things, being given either, we don't know exactly, it could have been barbiturates or it could have been benzodiazepines to sort of help get them through the days. But if you take too much of some of these, they can be bad, especially if you combine them with alcohol. Now, in general, when it comes to benzodiazepine drugs, they have a particular structure, and that's why they're called benzodiazepines. There are non-benzodiazepine drugs. These are referred to as Z drugs. We'll talk about them shortly. They interact with the same receptors, but they have a different structure to them. And so they're a little bit different, tend to be safer, but also have some other little weirder side effects associated with them. So when you're looking at benzodiazepine, lorazepam, there's a whole bunch of them. Most of them end in zapam. Okay, and the way that they work is they enhance the actions of GABA in the body by binding to these benzodiazepine receptors and having a calming effect, which is indicated for insomnia. They can also be used for anxiety to have a calming effect. It's not the first line drug for anxiety. Usually we give, or medical doctors will give, antidepressants for this because they tend to be less habit forming and less potential for abuse. And you can also use benzodiazepines acutely, like as an IV form, to help with people having like an epileptic fit, and also in other dosage as a muscle relaxant if you're taking it orally. Now, one of the things to be aware of, there are potential interactions when you're using a benzodiazepine. So if you take it with other sedatives, you're going to enhance the effects. So if you take, let's say, you're drunk and you take a bunch of benzos, you're probably going to be knocked unconscious. Barbiturates, which are not prescribed very often anymore, have a huge potential for interaction and a very dangerous interaction. And then finally, herbs like valerian and kava, all those herbs we discussed earlier on that interact with benzodiazepine receptors, could be potentiating the action of those drugs. And so one of the things that I've found in practice is usually if someone's taking a benzo and then they take one of these herbs on top of it, it usually will enhance the effects of that drug and make them a little bit more sleepy. So you want to be careful, but the interaction is not too dangerous because I find with the valerian and these other things, um, they're pretty gentle. So if someone's not on a really high dose and they're taking it as needed, often I'll tell them, look, try taking the valerian or the skull cap or whatever it is first. If you need to, then you can maybe take a little bit of your other sleep aid. One of the main indications I like for the nervine herbs is if someone has been taking a benzodiazepine drug long term, and now they want to switch to something more natural, you can often get them to, as they decrease the dose of the benzo that they're taking, they can start increasing the dose of things like valerian or whatever it may be, to help wean them off those drugs and decrease dependencies. Uh, a lot of these, often as an aside, people who are going through drug withdrawals or alcohol withdrawals, they may be given benzodiazepines to help with some of the withdrawal symptoms, because when you drink a lot, the alcohol acts as a strong sedative on the body and your body becomes adjusted or dependent on it. And then when you suddenly remove the alcohol, the nervous system that's been suppressed for so long now becomes hyper excited, and as a result can cause convulsions and even death in serious situations. So benzodiazepines are sometimes recommended as for support to go through for alcoholics if they're discontinuing the alcohol. So what are the side effects associated with benzodiazepines? If you've ever taken one, and I've only taken them once in my life, and that was when I was traveling in India, and I had to go on a 14-hour overnight bus ride, and I was sort of dreading it because Indian buses are pretty small. They're not very comfortable, and I was on a bit of a shoestring budget at the time because I was in my early 20s. And I remember someone gave me a couple of Valium or benzodiazepines to just said, look, pop them before when you get on the bus before you want to go to sleep. It'll just sort of help relax you and get you to sleep. And so I thought, okay, why not? I'll just give it a try. I remember popping them in my mouth, and then I just sort of looked out the window, and I kind of looked at my watch, and it was about 10 o'clock, and then I kind of looked out the window, and then I looked back at my watch, and it was like 11 o'clock, and I was thinking to myself, oh my gosh, an hour just went by, and I don't even know where I was. So it kind of leaves you zoned out. I did sleep pretty good. I was pretty groggy the next day. Definitely my thinking was pretty cloudy. So they work like a charm, but the main side effects is people feel groggy the next day. That's sort of the hangover effect. And when you're on them, you might experience some confusion or cloudiness because it's impairing your nervous system to some degree. At high enough dosage, it'll affect your ability to move and react to things because it's affecting your muscles. So you're going to develop maybe, you might be stumbling around, and that's what's called ataxia. And one of the disturbing things about them is that they can cause anterograde amnesia. So if you take a very short-acting benzo, it will make people sort of black out and not remember what happened. And these have been, when you hear about quote-unquote date rape drugs, some of these are benzodiazepines, because they sort of knock the person unconscious and or make them semi-conscious, and they don't really have any kind of recollection of what happens during that period of time. Now, one of the issues that people are taking benzodiazepines in high amounts for long periods of time, and then they suddenly discontinue them, they're going to get themselves into trouble because there is not only an addictive component to it, but you become physically dependent on them. And by removing them abruptly, you could start feeling really agitated or irritated. Your muscles might start twitching or convulsing. You might start developing insomnia, and there's the potential for seizures to occur with that as well. Now, I don't think most people that you see in practice are going to be on that level. They usually are given, like, here's 1 or 2 milligrams to take as needed. But if they're taking high amounts long term because they have a lot of serious mental health, you don't want to just say, oh, don't take those drugs. Drugs are bad for you. Discontinue it, and here's something else instead. You want to do this very carefully. You want to make sure that their medical doctor, whoever prescribed it, is the one involved with discontinuing those medications, like most medications. But when people come in and they're taking them as needed, then they really are the ones controlling the dose. So I don't really mind introducing herbal nervines and telling them just avoid taking them or cut the dose a little bit if you can. And that's typically fine, but you do have to be careful. Now, there are long-acting and short-acting benzos. The main difference between the two is that the long-acting ones means they keep you knocked out, and they may be active for 7, 8, 9 hours. The shorter-acting ones, the benefit of these guys is that they kick in, they're kind of like, they knock you out, they put you to sleep. They tend not to make you as groggy because they only have a short duration, short intense duration. So you don't tend to get as many side effects. The only problem is during that short period you might be more vulnerable or might have more amnesia associated with it because they kind of knock you out for that short period of time significantly. Now a little mnemonic just for fun, just so you know, because this is something that when you're learning pharmacology, I can't possibly remember all the names of the drugs, but one thing you'll see is that most of the benzodiazepine drugs end in zapam. So you've got lorazepam, diazepam. Now, some of them also end in zolam. So alprazolam would be an example. So if you remember the endings, it doesn't mean it's always, 9 times out of 10, I think, or maybe even 99% of the time, you're probably going to be okay if you can remember that. Now, one thing to be careful about is benzodiazepines end in Z-E-P-I-N-E. And what you have to be careful about is don't confuse that drugs that end in zipine are benzodiazepams, okay, or benzodiazepines, because carbamazepine is actually a drug used to treat seizures, so it's not a benzodiazepine. So if you're looking through the drug list that someone might be on a drug, you might confuse them for that reason. Also, clozapine, olanzapine are atypical antipsychotics, and that's would be easy to get confused on that one as well. So watch out for those various spellings. I don't know what you're going to be tested on for the exam, but just for life in general and seeing patients, this slide might help you just as a mnemonic, okay? Now, when it comes to sedatives and hypnotics, we're now going to talk about the non-benzodiazepines, or the Z drugs. So Z drugs, these are used more, I see them in practice more and more now than even 10 years ago. People weren't using them as much, and the benzos were the main drugs. So these are functionally almost identical to the benzodiazepines. So they're used for the same reasons, to help people fall asleep and have a bit of a calming effect. The main advantage is that they are safer and it's harder to overdose on these things, and they're less addictive. Now, structurally, if I look at that, it has a very different structure than benzodiazepine. And if you look in the middle there, both of these compounds, you see that group that has the 6-membered ring with the 5-member ring attached to it. That has like almost like a serotonin-like structure to it. It's like an indo compound is what that is. And we know that indo compounds interact with melatonin receptors, serotonin receptors, and serotonin, if you stimulate certain serotonin receptors in the body, they can affect mood, but they can also affect consciousness and cause hallucinations. Now, the reason why I mention that up is one of the disadvantages of this is 2 things. It can cause pronounced amnesia, so people forget what's going on when they're taking it. But the other thing is it can cause hallucinations in some vulnerable groups or just some people in general. So depending on the dose and depending on the individual's biochemistry, people who are taking these might become a little delusional. And especially if you combine these drugs with, let's say, other drugs like a selective serotonin reuptake inhibitor. So there's potential for there to be interactions with these because of the effects it could have on serotonin receptors. And also the natural supplement, if you gave them 5-HTP, there could be enhancement of the hallucinations in theory. Now, to give you an example of this, I see a lot of patients on these drugs. Now, my wife's grandfather, who is 99 years old, he was having some difficulties urinating. He was getting some really bad urine retention, probably because at 99 his prostate was the size of like a football. But so he went into the hospital acutely to deal with the urinary retention, and he doesn't like being in hospitals very much. And so one of the things that occurred was because he was agitated and couldn't sleep, they gave him a drug called zopiclone, which is a pretty common drug for people to be given to help them sleep. But if you look at the indications for zopiclone, they generally say it's used with caution in elderly because it can cause hallucinations and they can have serious side effects. And what ended up happening is because he was on that, and I would say combined with the stress of being in the hospital, he went a little bit, I'd say a little bit psychotic, a little bit delusional there. He thought that people were kidnapping. He thought the nurses were out to get him. And so what happened was he sort of started getting really upset, was throwing things at people, wasn't cooperating. And because he was acting a little bit psychotic, then what they ended up doing is they now gave him an antipsychotic called haloperidol, which basically is given to people with schizophrenia or when people are having psychotic episodes. Now, the unfortunate thing is one of the side effects of taking some of these antipsychotics is urinary retention. So we had this vicious circle going on where he went to the hospital, couldn't pee. They gave him and then he got agitated, so they gave him a drug to try to calm him down. Now the drug made him a little bit kooky, and then in order to manage him, they gave him another drug that made him not pee. Now he can't pee even more, so now he's getting more upset and staying in the hospital longer. And so things just sort of escalated. And eventually I sort of stepped in and said, look, let me see what drugs he's on. And we looked at them all. I said, look, don't give him zopiclone. And it even says in these CPS that used with caution. And he was given the adult dose for this drug. And when you are 99 years old, your liver does not work as well as a 40-year-old. So you could use some common sense. He shouldn't have been on that dose. He should have been on a much lower dose. Anyways, to make a long story a little less long, we got him off of all the medications, told him to stop giving him drugs because he's just too old for drugs at this point. And we gave him a little bit of melatonin, and a few days later, everything was back to normal. So watch out for drugs. In average and normal adults, you don't really see these issues. It's more in the elderly, and also when you're combining with other sorts of medications. So they're relatively good drugs, but you got to be careful. Just as a side note, I was reading the other day, the man who was responsible for creating the Cochrane reviews, and so this is sort of the most revered way of analyzing evidence-based medicine, is doing a Cochrane review, and you combine all the clinical trials and tease out the good and the bad and everything else. And so this is based on good evidence, the best type of evidence-based medicine. So the guy who founded this went on this rant on the internet or in an interview saying that medical doctors are overprescribing drugs in general, and in particular drugs that act on the nervous system, antidepressants and sedatives, are being overprescribed and prescribed at much higher doses than they need to be prescribed at. And that this is, just a terrible thing. And so this is a medical doctor and researchers saying that doctors are using way too many of these drugs that act on the nervous system. So I have to agree, they have a place, but if you just have a little trouble sleeping, you shouldn't be giving these guys. So we talked about some of the side effects with them. A few other things: you might get a dry mouth, it disrupts your REM sleep. Some of the rare symptoms, as I mentioned, hallucinations, sleepwalking, weird night eating behaviors, and then in very serious situations would be aggression, which I think Grandpa was getting, and along with hallucinations. Also some depression, which he was getting. Suicidal ideation wasn't something that he was getting, but that can occur as well. So in general, if you're taking a high dose, or if you're really old, there's probably a greater risk of these side effects appearing. And the other weird side effect that you get with these that you don't see with the benzos is the bitter metallic taste that they produce. And so that's an unusual thing with them. Both benzos and the Z drugs. And they call them Z drugs is because one, they all start with the letter Z, and that's one way to memorize. I don't know if I wrote that down or not, but if you look at all the Z drugs, um, they all start with the letter Z, and the way that I remember it is that the Z drugs help you get your Z's. You know, when you're sleeping, you make those little pictures. They have the Z's above your head. So that's another way of remember the non-benzodiazepines are the Z drugs. Now, a couple other sedatives and hypnotics we'll talk about. Diphenhydramine. So when you take Nitol or some of the other sleep products on the market, Gravol, Sleep Ease, these use an antihistamine. Now, antihistamines, they inhibit histamine in the body, and histamine has a number of interesting functions. So when you look at Gravol, for example, Gravol is used as an antiemetic to help settle an upset stomach. So it's used for motion sickness, for example. Nitol is used to help people sleep. And these same drugs are also used to help treat symptoms of allergies. So what I find interesting about antihistamines is they're a great drug to travel with because you can use it for sleep, you can use it for an allergic reaction of some sort, seasonal allergies, and also to help with motion sickness or seasickness. So it's one of the few medications I actually travel with. And what's interesting is the difference between a lot of the products on the market, they may have the same drug but a different package depending on what indication they're trying to promote. So if it's promoting sleep, it might be Nitol. If it's promoting motion sickness, they might use something like Gravol. But they will use, or if it's used for seasonal allergies, it's another packaging they'll use. So so they can be used as a sedative. They're available over the counter. The mechanism is it interacts with histamine receptors, which play a role in consciousness. And then muscarinic receptors, they also have an effect on, which is involved in act as probably a bit of an antagonist for those, and that's maybe where you get your antiemetic effect. So there's lots of benefits of these drugs. I don't particularly like medications, but sometimes it's good to have these medications if you're in a serious situation where someone's feeling sick, they can't sleep, or you might have allergic shock. It's a good one to have in your backpack if you're traveling around. So, and the final medication we'll talk about for sleep aid is melatonin. Melatonin is primarily a neurotransmitter or hormone involved in maintaining or creating the circadian rhythm. So when it's dark outside, we get more melatonin being released. In the body, just as an aside, tryptophan gets converted to 5-HTP, which gets converted to serotonin, which then gets converted to melatonin. So if you give someone 5-HTP for depression, it can also elevate melatonin levels. And another thing is that vitamin B6 is involved with the synthesis of serotonin and melatonin. And so if someone's having, let's say, difficulty sleeping, they're on the birth control pill, which depletes B6, a very gentle thing to do is you might give them some B6, some melatonin, or 5-HTP, and it might help with that. And there are other drugs that deplete it as well. Now, we've talked about sedatives, we've talked about benzodiazepine receptors. This is a little fun little side note. We'll talk about voltage-gated ion channels and how they're manipulated to have an effect on medicine. When you look at the voltage-gated ion channels, there are different ones that allow for the influx of positive ions, also referred to as cations. So some of them will target sodium, other ones potassium, some of them calcium. Those are all different things that basically cause the cells to depolarize. Now here's a little picture of a zombie. It seems a little out of context. There's a reason for this. Here's also a picture of a sushi chef from a Simpsons episode making fugu. So anyone know what the connection is here? When it comes to the pufferfish, it's highly toxic, and there's only a small sliver of meat that you can eat on this that's safe, uh, and the rest of it contains a potent neurotoxin. And in particular, the liver, the ovaries, the kidneys have high amounts of this neurotoxin in it. And the reason why that's discussed is there is a book written by an individual called Wade Davis. And I love Wade Davis's books. He's fantastic. He's an ethnobotanist who's done a lot of work in the Amazon. And he's one of the chief, I don't know his title, but he works for National Geographic now, and travels around the world promoting the importance of preserving not just plants, but also culture in the form of language. And so he's an ethnobotanist, and he was hired to go down to Haiti. And in Haiti, there's still, it's still fairly isolated culture, and there's a lot of people practicing voodoo in Haiti still. And I've never been there, but I've had a few friends who've been there, and they do mention that you can definitely feel its presence there, and there's some weird things kind of going on. And Haiti is a religion that came out of West Africa that came over when the slaves were captured and brought over to work in the Caribbean in the various plantations. And a part of Haitian culture is making zombies. And so the weird thing with zombies is that they originated in Haitian culture, and it's the idea that the priest in the society or the cleric, or whatever his title would be, he knows the rites and rituals to make zombies. And so what happened down in Haiti, that a woman died, and decades later, or maybe 10 years later, I can't remember the details, she was found sort of in the stupor walking around town, and she was pronounced dead before, and now here she was alive. And so they heard about these reports, and so somebody hired Wade Davis to go down there to explore this and see if he could figure out what was behind the zombie rumors and myths. And so what's interesting with when he went down there, now this is debated by various academics, but what he found was that people were the zombies portrayed in Haitian culture are very different than the ones that are portrayed in The Walking Dead on television or in movies. Down there, what happens is that the zombie master, he uses the threat of converting people into a zombie as a way to control order in the community. And if you're misbehaving, then watch out, he could turn you into a zombie. So what ends up happening is, and a lot of the people are just not so afraid of being attacked by a zombie, but rather of being turned into a zombie, because you basically become a slave. And so what Wade Davis revealed when he was doing his little exploration was that he found that the zombie masters were probably using pufferfish, and so that goes back to the original slide that I showed you with the fugu fish. They were using pufferfish, and what pufferfish do is they have a toxin in it that target various voltage-gated ion channels in the body to inhibit nerve function and cause people's nervous system to go to almost like a complete, they're almost paralyzed, or their whole nervous system shuts right down. And if you get the right dose, the heartbeat will become so slow and the breathing will become so slow that most doctors would not pick up on the heartbeat or the breathing, and they would just be what do you call it, undiagnosed, but they'd be told that they're dead, and then they get buried. And then what would happen later on is that the zombie master would go along and dig them back up. Probably they'd be suffering from a little bit of hypoxia because they're now not getting enough oxygen, so maybe there might be a little bit of brain damage, and as a result, they would make them a slave, maybe give them some other herbs, like Datura would be one of the herbs that was given to them to kind of keep them drugged up in a stupor, and then they make them a slave to help them, I guess, run errands or whatever zombie masters use them for. So going back to what's the relevance here, that just creates some fun little context for voltage-gated ion channels. Now, we mentioned already these things are involved in conducting the nerve impulse, but certain toxins like tetrodotoxin, TTX, you'll find this in pufferfish, and this is the same fugu sushi contains this. And so if you were to get the right dose of sushi, it tastes great, and it might cause just a mild tingling of the lips, and that's sort of a desired thing. Now, in addition to the pufferfish, there are other fish in the ocean, like porcupine fish, triggerfish, parrotfish, and blue-ringed octopuses, who also accumulate this toxin in their body. And this toxin, um, I believe it's in certain corals and algae, and then it accumulates in the organs of the animals that eat those corals or algae that produce it, and then it accumulates in the liver and the ovaries and the kidneys and things like that. And the mechanism behind this is it binds to voltage dependent sodium channels and basically blocks these. And so in the beginning, you might get a mild tingling sensation in your lips or in your tongue. And in the short form, it causes hyperstimulation of some of the nerves, causing increased salivation, sweating, nausea, vomiting, diarrhea. So it's kind of the symptoms of food poisoning. And then it's followed later on by a depressant effect, which results in generalized weakness of the muscles, difficulties talking, and then difficulties breathing. And if it's high enough dose, it will result in death and cardiac failure. So certainly when the Haitian zombie masters were making zombies, I'm sure occasionally they didn't quite get the right dose, and you'd end up killing a few people before you got that perfect little dose that you could get a zombie out of them. Another thing that's a little bit disturbing in Japan, where they would give fugu, there are still deaths reported each year from people not quite getting the right dose. They're not that common, but they do occur. I don't know if it's every year, but they certainly have occurred. If you're a sushi chef, you have to be specially trained on how to prepare this fugu. But one of the things that they found is that when they were moving cemeteries and moving coffins, sometimes you might find on the inside of the coffins there'd be scratch marks. And probably what happened was that some people were poisoned by this, and they went into this sort of coma that was, and their breathing and the respiration and the heart rate was basically almost to zero. And then as slowly over time, as the drug was processed by the body, 24 hours, 48 hours later, maybe the person in the coffin will wake up and realize that something was, that they were trapped in some sort of coffin or whatever, and then they start screaming and trying to get out, and they couldn't. So a little bit disturbing, but this is all fun stuff that nightmares are made from. So, and that's related to an example of a nerve toxin. So one of the things that it does, for example, the TTX, that's a little yellow thing there, it goes in and blocks these voltage-gated ion channels, and as a result, what happens, it blocks it open initially. So what happens is that it causes hyper stimulation of the nerves by depolarizing them and leaving them wide open, and as a result, you get, in the short term, stimulation of these nerves, and then not long term, as you kind of deplete the nerves and they're no longer to depolarize again, then they kind of get stuck full on, and then eventually it causes paralysis and all these other symptoms. So there can be an acute initial excitation followed by a depressant effect. Now, just as an aside note, lamotrigine, which is a drug that used for bipolar, it's also used for epilepsy. It acts as an agonist for these, or an antagonist for these receptors. So it goes in there and blocks these channels. It doesn't have any initial stimulatory effect. It only has an inhibitory effect, and basically helps to dampen the nerve functions in general. We'll talk about it a little bit later on, but that's where lamotrigine works. And there are other drugs that can target these guys as well. We'll talk about in a second. So certain drugs that block these voltage-gated ion channels will have a dampening or inhibitory effect on the nervous system in general. Now, for fun, when you're looking at herbal medicine, you may have heard of aconite. It's also referred to as monkshood or wolfbane. And aconite it's used in Chinese medicine for a number of things, and it's cured a special way to reduce the toxicity. But one of the main actions for this is that it blocks the voltage-gated sodium channels in the body. And so it's an extremely dangerous plant, probably the most dangerous plant you can find in Canada. I have seen it growing in people's gardens. They're probably not aware of it. There was one reported death of a Canadian actor who was, I can't remember his name, might come to me in a second. He was traveling in Newfoundland and on a hike. I don't know why, but he um, took a few of these flowers and ate them. Maybe didn't realize what they were, and it only takes a couple of these to cause death. And I guess they're too far away, or they weren't able to do a whole lot to help him, and he died from it. So this is an extremely toxic substance. I would be scared about even getting it on your skin because you could ingest small amounts that way. It's act as a nerve block. Aconite. It is taken internally in Chinese medicine, but it's a very narrow therapeutic index, so you don't want to mess around with it. It can also be applied topically to act as a nerve block to have some effects. I've never eaten it. I have just, out of curiosity, rubbed a little bit on my lips to see what happens, and it does cause a numbness and tingling in your lips. And so in high amounts, it will cause symptoms, poisoning symptoms, probably a lot like the TTX toxin. So if you don't have access to a puffer fish, fugu fish, and you want to make a zombie, you could probably use a monk's hood for the same mechanism. So that's kind of like the herbal equivalent to make zombies, I suspect. Now, I've never made a zombie, but that might be one thing you could use for it. So another interesting thing about the plant was historically it was used to kill animals, and that's why it's called wolfbane. So they might dip spears or arrows in aconite to make it even more deadly. Also, this is another neurotoxin that has been used in literature or movies to assassinate or to kill people. So I remember reading about one particular reference where it was described by a Latin author as a really useful plant to help you get rid of undesirable individuals. So not that I'm recommending that, but if you had to get rid of someone, this would be a great herb for that. Just kidding. Now, just to also to give you some examples of how toxic it is, there are 7 cases of fatal aconite poisoning over the last several years. I don't know what the dates were, 1999 to 2008. So about 10 years, they were looking at about 7 cases of death reported to the aconite, and they just didn't quite get the formula right. So, why bother? Why bother using it? I don't think you need to. And here's BBC News, curry poison killer. So here's a woman who got a little bit upset with her husband and decided to get rid of him. And the way she did that was she gave him aconite to get rid of him. So there you go. Don't know a lot more about that. Here, oh yeah, I don't remember putting this in. So here's just someone gave an antidote. We're giving a high dose of magnesium sulfate, so Epsom salts, in the treatment of aconite poisoning. So that's just sort of interesting. Anyways. So I'm going to take a couple-minute break and pause the recording, and then I'll be back to cover the anesthetics and a couple more things before we end the lecture for today. Okay. So we've got 2 more areas we want to cover today. One will be anesthetics. The second one will be anti-epileptic drugs. And to begin with anesthetics, now, to give you a couple terms, an analgesic is a substance that relieves pain but does not affect sensation. An anesthetic, on the other hand, is something that reduces pain, but it does alter the sensation as well. So anesthetic means no sensation or no feeling. So kind of numbs the area. So you have, excuse me 1 second. Sorry. So a local anesthetic is a substance that's applied topically or injected into an area specifically for surgeries, or that would be one of the main things, and it has sort of a numbing effect, but the person typically remains conscious. Now, when you use a general anesthetic, you're looking at having someone inhale a substance, or maybe it may be injected IV into the body, and the idea is you kind of knock the person out, or you just suppress the nervous system enough so that the person doesn't feel anything. Now, starting off with the local anesthetics, most of these, I'm sure everyone's experienced some of these to some degree, at least hopefully just the first two. Benzocaine, lidocaine, these are a type of local anesthetic that are referred to as esters. There are other ones that are amides called lidocaine, and these guys, don't worry about the difference from them for now, but what they do is they basically block voltage-dependent sodium channels and prevent depolarization of the sensory nerves. Now, just as an aside, uh, cocaine from the coca plant, which is a drug, in addition to making people high and having a large effect on dopamine release on the body, it also has a numbing effect. So if you've ever seen in movies, or if you've ever seen anyone at a bar or club and they're doing a lot of tickling their nose, it may be because they've taken cocaine and it's sort of numbing the sensation in the nose and having that tingling effect like a lot of these guys do. Cocaine can also be used as a building block to make other pharmaceutical drugs. And it is can also have a local anesthetic effect. Now, the way that these guys work, remember when we're looking at the pictures with the TTX toxin, here are the anesthetics like benzocaine. It'll go right inside the voltage-gated ion channels and prevent the influx of sodium or potassium or calcium when there's basically the depolarization of the nerve. And these things are reversible. If you've ever had, let's say, your wisdom teeth taken out and they injected you with some sort of anesthetic, the whole area becomes numb and you can't feel anything for a period of time, and then eventually it wears off after a few hours. Now, one of the things that's interesting about this is local anesthetics, they seem to have an affinity more for certain nerves involved with pain sensations they have the greatest effect on, but also on things like temperature, cold, more so than heat, some effect on touch, and less of an effect on deep pressure. So if you've ever had a tooth extracted, you may notice that you can't feel the pain, but you can feel kind of a dull sensation when they're kind of squeezing or pushing on the tooth, and when they rip it out, you can feel the tugging, you can feel some pressure there, but you're not experiencing the pain. So not all sensations completely dulled, but certainly the pain and temperature sensations are affected the most. And then depending on, going back up to the first thing, different ways to administer this, it may be, you could have an analgesic cream that's, or an anesthetic cream that's applied topically to numb the local tissues. You might inject it into the tooth or into the spine or into the epidural to have an effect. That's a little bit more localized or widespread depending on what you need. Now, when it comes to anesthetics, the inhalational anesthetics are ones that are typically applied. Let's say you're going in for surgery, you're having dental work done, they may put a little mask on you, and you may breathe these in. And there are different ones that can occur. For example, laughing gas, nitrous oxide. It's the safest probably of all these. And it just has kind of a dissociative hallucinogen effect and also numbs pain. Then you get into things like ether and chloroform. If you remember back in all the spy movies that you'd see, someone always sneaks up behind somebody with a cloth covered in chloroform or ether, and they put it over top of their face and they breathe it in and they pass out. If you remember those things like chloroform, it does cause people to go unconscious. In a hospital settings, they'll use things like halothane. Now, one of the things with chloroform and halothane, if you look at it just as a side note, the chlorine molecules and the fluoride molecules on those structures, when it gets processed by the liver, they become reactive compounds that can cause a lot of issues with the liver and cause some liver damage. So they're very, very hard on the liver. And so they can cause a lot of a hangover, kind of like feels like you've drunk a lot of alcohol and you feel hungover, where you get nausea and vomiting just because of the damage to the liver. In really high amounts, it can also cause death. Occasionally, people have a really bad reaction to them. So going in for any surgery where you're doing some kind of general anesthetic, there are risks associated with just having a bad drug reaction to it. And in general, if you're on these, they probably will have you artificially ventilated because it'll shut down your natural respiration function in the body, and you need to have that. Now, I'm a little out of order here. The precise mechanism is unknown. I suspect it goes in and just, these are relatively small molecules that kind of go in and disrupt nerve function in general. It appears that enhance GABA and glycine receptors while inhibiting NMDA receptors, glutamate receptors in the body. So you're having a calming effect by a few mechanisms there. And also they're going to go and interfere with these various ligand-gated ion channels, and I would imagine there's probably some effect on the voltage-gated ion channels as well. So in a non-specific way, they're sort of just messing up all these various receptors involved with the nervous system. Just as an aside, milk thistle might help to decrease the toxicity associated with some of these general anesthetics. It increases glutathione, helps protect the liver as well. The only challenge is you're not supposed to take anything right before surgery, so you might want to have some preload on this before going in for surgery and then discontinue the 24 hours before. They haven't done any research to see if it has benefit, but I wouldn't be surprised if it does. Just as a digression, you don't need to know this for the exam, but Michael Jackson's death, if you're kind of wondering what happened to him, when he passed away, I think most people know that Michael Jackson had a lot of anxieties, and one of the things is he kind of demanded his medical doctor give him stronger and stronger drugs. And so at the time of his death, they basically found 3 benzodiazepines in his body, and they also found propofol. And what's weird about propofol, sometimes referred to as milk, because when it's given IV, it causes like a milky precipitation to occur. And it's a very, very potent sedative. It's typically only used in surgery settings, and its mechanisms it blocks GABA and also acts as a voltage, blocks the voltage-dependent sodium channels. So it does have a very relaxing effect for surgeries, or if you're trying to insert medical devices into the trachea or doing things like endoscopy. The problem is under the situation, he was taking a number of different benzodiazepines that weren't relieving his anxiety and helping him sleep, so he demanded his personal doctor to give him a stronger drug, and so he hooked him up to an IV with the propofol, and then it left the room for a couple of minutes. When he came back, he was dead. So anyways, I was just kind of curious. I wanted to look it up in case you're interested. There you go. But that's not needed for exam purposes. Now, the next group of drugs that we're going to talk about are anti-epileptic drugs used to treat various types of seizures. I'm not going to go into the background on the different seizures very much. You can read the slides. You can read up more on the pathophysiology. I'll focus more just on the various drug classes that are used. I find this area is constantly changing, and the standards of practice from when I first created the lectures till now, they've changed, and different guidelines are different in the US or Canada. So I'm going to mention a bunch of drugs. I don't know what the first-line therapies are these days. I did have a look recently. I think I know, but I'm not positive. Basically, to give you a little background on seizures, a seizure is basically when, or epilepsy is when the nervous system just starts to discharge and all the nerves start firing out of control, resulting in different types of presentations depending on the nerves that they're affecting. So the main cause of seizures is sometimes, or in most cases, idiopathic, meaning we don't know what's going on. There could be some kind of dysfunction in the nervous system, whether it's maybe an underexpression of GABA or an overexpression of glutamate, or something's causing the ion-gated channels to open up. But it can also happen to even healthy individuals if they experience some type of trauma to the head, maybe cancer or a stroke or concussion. Under certain extreme cases of stress, people will sometimes have seizures. So maybe going through a breakup, or a loved one has passed away, or there's sleep deprivation. And also people who are experience hypoglycemic episodes for diabetics, that can induce a seizure. Certain types of drug withdrawals, as we mentioned earlier, people going off of benzodiazepines or stopping drinking alcohol right away can cause seizures and also with fever. And I keep scratching my nose, not because I've been doing cocaine, but because my whiskers are tickling my nose. So I'm going to try to control that, but it's driving me nuts right now. Anyways, epilepsy, chronic recurrent seizure disorder. So a lot of the time we don't know what the cause of it is. There's partial seizures that affect a certain part of the brain and develop certain symptoms. There's also generalized seizures that can be tonic-clonic or grand mal. These are sort of the classic presentation where the entire nervous system is affected, and typically I've only seen it a couple times where someone will fall on the ground and just start convulsing. They typically are unconscious, and it's quite pronounced and a bit scary to witness. There's also the petit mal or absent seizures where someone might just lose consciousness for 30 seconds and they may or may not have any sort of motor activity, so they don't get the scratching. Sorry, not scratching, I'm scratching. They might get the muscle contractions and flailing about. So when it comes to, in general, anti-epileptic drugs or anticonvulsant drugs or anti-seizure drugs are typically used for chronic situations. So they aren't typically used acutely. It's used more for a chronic treatment, so given on a daily basis to prevent them from occurring. And the main classes will include barbiturates, hydantones, benzodiazepine, succinimides, and also newer anti-epileptic drugs. And typically the type of drugs that they give, there are first-line therapies done depending on the type of seizures that you have. So in general, the mechanism will probably involve some sort of inhibition of the cation channels like sodium or potassium channels. It might enhance GABA, or maybe they inhibit glutamate systems as well. So in general, that's what's going on there. So here's a whole list of them that you can look at for various drugs. You can see there's certain ones that are first choice drugs for certain types of seizures, second choice for other types. You can read through that. I don't know how important it is to memorize what is the first choice for which ones, but I'm just providing you with all that information there. I don't think there's much here we got to consider. Let's see. They have to choose a particular drug for the type of seizure. They usually titrate the dose up so that you can get the dose required to prevent the seizures without causing any sort of toxicity. Some of these you'll need to measure drug levels in the serum. Typically, they like to give one drug if they can, but sometimes if they can't control it, they'll give multiple drugs, like a second or even a third agent. Oh, sounds like my baby's in the background. I don't know if you can hear. And one of the most important things is that when someone's on anti-epileptic drugs, you never want to discontinue this abruptly, because just like with alcohol withdrawal or benzodiazepine withdrawal, when you're sedating or suppressing the nervous system, if you just discontinue that right away, it can cause the body to become overexcited and induce seizures. It's kind of like if you take a beach ball and you push it underneath the water. You keep it under, and then you remove your hand away, kind of like discontinuing the drug. That ball comes bouncing back out of the water, and you know, kind of has that rebound effect. And so that's the same thing that happens with your nervous system when you sedate it. There's lots of different interactions, like naturopathic interactions. Evening primrose may or may not. I'm not convinced it has a major effect on anti-epileptic drugs, but there is some concern about that. Grapefruit juice interacts with a lot of the anti-epileptic drugs, mainly because they're metabolized by various liver enzymes, and grapefruit juice will interact with, or basically inhibit those enzymes, therefore elevating the drug levels in the system. St. John's wort does the exact opposite of grapefruit juice. It basically induces those enzymes, so it can decrease the levels of those drugs. And if you do that of certain drugs, and if you do that, it could make the drug less effective. Taking the herbal sedatives that work on the GABA system could enhance or potentiate the actions of a lot of these drugs, including barbiturates. Phenytoin is one of the important things about that is it does affect folic acid and vitamin D, and that's sort of a good thing to remember. And occasionally, right now I probably have 2 patients on phenytoin, and they should be supplementing with folic acid and vitamin D. Um, some of the other drugs affect B vitamins, including biotin. So barbiturates. So we're going to start with barbiturates, not because they're the most commonly used drugs, but historically they're some of the first ones that came on the market. And to put a little cultural context in here, there's been a lot of famous people that have whose deaths have been related to the use of barbiturates. So Judy Garland from The Wizard of Oz, apparently she may have overdosed on barbiturates. Marilyn Monroe, barbiturates may have played a role in her death. Now, it wouldn't be the only thing that she was taking, I don't think, but it may have been one of the drugs. Elvis, he was on all sorts of things when they performed the autopsy, and barbiturates was just one of the things that he was taking. I'm sure, I remember reading he may have been on a couple of benzos, a barbiturate, some alcohol. Jimi Hendrix, like a lot of rock stars in the 60s, a bunch of them died from, maybe they drowned in their own vomit. That's what they think. But he may have been drinking and taking barbiturates and combining with other drugs to have that to cause death. The main thing now is that you don't hear about people overdosing very often and dying, not as much as they used to. Certainly there are some people. Obviously, opiates now are the biggest things that seems to be the what all the media is talking about. But barbiturates, they're rarely used anymore. In the 60s and 50s, they were prescribed just to help with sleep because they are sedatives and they can help with anxiety as well. So remember when we were talking about Mother's Little Helper, barbiturates are often referred to as Mother's Little Helper as well, to kind of help decrease anxiety and get rid of all the troubles that the woman's having. Now, currently they're used primarily for seizures, but they're not the first choice because of safety concerns. Second of all, they were historically used for insomnia and anxiety, but they're no longer used because of the deaths associated with it. And in particular, when you combine them with other sedatives like alcohol, that's where you can get yourself into trouble. Now, the main mechanism of action is that they don't target a single receptor in the body, but they have an effect on GABA through some unique receptor. That's not related to the benzo or the GABA receptors. They also antagonize or decrease the effects of the MDA receptors. So they block the glutamate receptors. And they may have some effect on the voltage-gated ion channels as well. And so the barbiturates, phenobarbital is one of the main ones that has been used. Side effects associated with this, like a lot of the drugs we're going to talk about, there's major similarities between them. So when you're basically dampening the nervous system, and it's kind of like taking the light on in your room and using the dimmer switch to turn it down a little bit, everything becomes slower. I had a patient who's on, I don't know if it was a barbiturate or if it was one of the phenytoins. I think it was one of the phenytoins. But their wife thought that he was suffering from dementia because he couldn't remember anything anymore. And when you look at the list of drugs that he's on, his anti-epileptic drugs that were probably, in my opinion, responsible for him being misdiagnosed as having dementia. So a lot of the effects of these drugs causes drowsiness just because you're sedated. You get this hangover-like effect when you're taking them, where you're feeling groggy, drowsy, lazy. Something that's unique for these is that in some cases people get a hypersensitive rash, and it's quite serious. The other thing that we mentioned is that people do develop tolerance to these, like a lot of the sedatives, and if you discontinue them abruptly, it can induce seizures as well. Now, with the interactions, if you take enough of a barbiturate alone, like if you take a bottle of pills and chug it back, it will cause death. You don't tend to see that when people overdose on, let's say, the Z drugs that we mentioned, or with benzodiazepines. You're probably not going to die from an overdose of benzos. Now, so when you look at it from a safety standpoint, probably valerian, chamomile, Cava, they're going to be the safest, then the benzos, and then when you get into barbiturates and some of these other anti-epileptic drugs, they're going to be the most toxic. So the other issue with these barbiturates is even if someone didn't deliberately mean to overdose, like if you're taking a whole bottle of pills, you're obviously trying to kill yourself. But a lot of people might take a few barbiturates to calm themselves down. They might be drunk or drink a whole bunch of alcohol at the same time. Maybe combine it with some other sedative, just meaning to have a good night's sleep or to relax, and then accidentally cause the respiratory system to shut down and die. So major concerns with interaction with other sedatives. The other thing that's worth noting is barbiturates. They are greatly affected by other drugs because they're metabolized by the various P450s in the liver. So other drugs that induce or inhibit the liver will affect these drugs. And also these drugs induce the various liver enzymes. So they can, not only will they be affected by other drugs, but they also affect other drugs. So the final thing is that they also deplete lots of vitamins in the body, including folic acid, vitamin D, vitamin K, biotin. So barbiturates take home as they're not particularly safe. We don't use them very often. They interact with lots of other drugs. One, other sedatives they'll interact with. Two, anything that affects the liver will affect these drugs. And these guys also affect other drugs in the system. So there's lots of interactions with everything going on there, including nutrients. So you got to watch out for them. Now, hydrotones are another class, very similar to barbiturates, but they tend to be a little safer. So phenytoin is one of the most commonly used ones. It's used primarily for epilepsy. A lot of the time when people come in who have a history of seizures or generalized seizures are commonly prescribed this drug. And there are many different, there's probably a few different mechanisms for it, but one of the things that it does is it blocks the sodium channels involved with the voltage-gated ion channels. So when it comes to drug interactions, just like the barbiturates, there's lots of interactions. Frankly, too many to mention. So just remember, there's tons and tons of interactions for both the barbiturates and the hydrotones. Now, these are relatively dangerous medications in the sense that it has a narrow therapeutic index. So you want to make sure that you get the dosage right, and you don't want to be messing around where you could be accidentally elevating the dose to toxic levels. The main side effects associated with it exactly the same as a lot of the other drugs we're going to talk about. Just the general sedation of the nervous system makes people tired, might affect their ability to walk. It might affect their concentration or their ability to recall and remember things. One of the symptoms that you might see is nystagmus when you're doing the eye exam. There's also drug reactions that can occur with this that can even be life-threatening, like the SJS is Stevenson-Johnson syndrome. It's rare, but it can be life-threatening. These drugs you don't want to give them to women that are pregnant because they're teratogenic, and they can, if you remember, terato means monster, genic means to make, so they can make little monsters or basically do bad things to the developing fetus. Now, taking it on a long-term basis, and you do see people coming in, if you know that someone's on anti-epileptic drugs, so what you want to do is have a look in their mouth, look at their gums, and see whether their gums are swollen. Also check their CBC to see whether or not they have any issues with their red blood cells being enlarged. That's megaloblastic anemia. And so the most important thing I would do is supplement with folate. You might consider giving them B12 as well. Other B vitamins might play a role, so just a multi-B might be an important thing to take. Also recommend a little higher than usual dose of vitamin D, and maybe have them get it checked periodically as well. When it comes to naturopathic considerations, a lot of the herbs that are sedatives have the potential to interact and make someone feel a little bit more drowsy. So you just got to be careful with that. I don't know if giving someone a cup of chamomile tea would be a major issue. but you got to monitor and let people know that they should be careful about that. Vitamin D, folate, biotin are all things that I would supplement with anyone who's taking these medications. So those, the first two that we mentioned, the barbiturates and the phenytoins, those are kind of some of the archetypal classic anti-epileptic drugs. Succinamides are a little bit newer. Um, these aren't used primarily for grand mal seizures. They're used more for absent seizures. It's a specific type of seizure, and there's benefit for that. And there's a few different ones on the market. They work by a slightly different mechanism. They inhibit the calcium channels, voltage-gated ion channels, and if you look at the structure of this, it's a relatively small compound, so it's probably going to be interacting with the channels themselves to sort of block the effects of it and inhibit depolarization of it. The side effects associated with it, many of the same things that we saw already: drowsiness, fatigue, lethargy, meaning just sort of feeling lazy, headaches, blurred vision. There's more of you can get some nausea and vomiting associated with it. And again, there's lots of interactions with other drugs. So these, I haven't seen any patients on these, I don't think. I think one patient I've seen on these, but it's out there. I don't really think there's anything else you need to know about it for now. Benzodiazepine. So we've already mentioned the benzos when it came to as a sedative or how people might use it for anxiety. These are not typically given to people who have a history of epilepsy, or it's not given to control epilepsy, but you might use them for maybe especially acutely if someone's having some sort of seizure, it might be given. So they're not the main drugs used, but they're a secondary drug. As we mentioned before, you do develop tolerance if you're taking these long term. And if you were to stop them abruptly, you're going to have some negative side effects and possibly aggravate seizures themselves. So we've already discussed these and just bringing them up again, that benzos are sometimes given to people with epilepsy. Now, let's just skip over that. Some of the newer drugs used to treat epilepsy. So, oops. So some of the ones that we're going to talk about now are carbamazepine, lamotrigine, and valproic acid. Most of these work by multiple mechanisms. Some of them will block the voltage-gated sodium channels. And we're going to start with carbamazepine. And remember, benzodiazepines, kind of a similar sort of ending as the carbamazepine. So don't get confused by that. It's a completely different class of drugs, and they work by a different mechanism. There is some effects that these guys have on the GABA system, but they also appear to have some effects on the sodium-gated ion channels. And so the main indications for these is epilepsy, but they're also recommended to people who experience like manic depressive episodes. So it has a mood stabilizing effect and may be used for people who experience bipolar disorder. Also, people suffering from certain types of neuralgias might be given this. It might be combined with other antipsychotic drugs in people with schizophrenia. Often people who have schizophrenia or severe depression and anxiety might be on multiple drugs, and this might be one that could be indicated for that. The main benefits, it does have a better safety profile and has less side effects than the barbiturates and the phenytoins and things like that. A lot of the side effects, similar sort of thing. Anything that depresses the nervous system is going to cause drowsiness, confusion, difficulties walking, dizziness. A lot of these guys also have nausea and vomiting, so nothing really significant there. It may affect sodium levels, so the hyponatremia is just basically means low sodium levels. And so that might need to be monitored over time. It also can affect the blood, cause leukopenias and different types of anemia, thrombocytopenias. The most serious thing is that in rare situations, it can cause a very serious and life-threatening type of skin reaction called toxic epidermal necrolysis. Like, it just doesn't sound very good. And also can cause Stevens-Johnson syndrome. So although it probably happens in 1 in 10,000 people, it's not something you want to have happen to you. So that's probably the scariest thing, but it doesn't happen very often, but when it does, it's bad, so you want to watch out for that. Drug interactions. There is lots of drug interactions. So those aren't good. Now, another drug, and I've seen people on both the lamotrigine and the carbamazepine. This is another drug, similar indication, as we mentioned before, used primarily for epilepsy, but also used for bipolar. So it's much safer than using lithium. And we will talk about bipolar a little bit later on, and the why people are given lithium salts and stuff like that. So the way that this works is that it inhibits the voltage-gated sodium channels and also has some sort of effect on the release of glutamate in the body. I'm sure there's other mechanisms. Often with a lot of these drugs, they don't know precisely how they work. They just know the effects that they have. It's just, I like to kind of have a rough idea how they work so I can somehow store them in my brain in the various compartments that are sort of associated with things. So interactions, you got lots of interactions here. It is metabolized by a glucuronic acid conjugation. So glucuronic acid is a type of sugar that gets stuck on a number of different phenol compounds. So lamotrigine uses the same thing. It's not affected by the CYP enzyme. So when you're looking at St. John's wort and grapefruit juice, they're metabolized by CYP3A4 and various other ones. Because it's not metabolized by it, you're not going to have as much of an issue with or you won't have an issue with grapefruit juice and combining it with lamotrigine. The other benefit is that it has less drug interactions because drugs that typically induce or inhibit the CYP enzymes, they won't have any major effects on this. So that's a positive thing for this. Some anti-epileptic drugs do induce glucuronidation, and so what that means is if you're upregulating the glucuronidation detoxification pathways, then you could potentially decrease the drug levels of lamotrigine. So we know that phenytoin, carbamazepine, phenobarbital, primidone do have an effect in that way. So there's not going to be an effect on the CYP enzymes, but there will be an effect with these other phase 2 conjugation reactions. So here, similar side effect profile that you'll get with the other anti-epileptic drugs. There is a skin rash that's relatively common, about 10%. So 10% means 1 in 10 people. So, and obviously you can do math, but 1 in 10 people, and so it will come up if you prescribe this to enough people, and 10's not that many. GI effects is pretty common with most of these, and then the usual CNS depressant effects that you see. Now, valproic acid, this is used for a few different indications. Valproate's used for, I should say, seizures on here as well. I don't know why I only have skeletal muscle spasms, but it's used for, I've seen it being used for people with epilepsy. I've also seen it for muscle spasms. Sometimes for neuropathies it's used, and the main mechanism of action is unknown. Although if you look at where it's basically showing the pink there, the pink structure is very similar, the pink component of it is like GABA, and so you would think that it would interact with the GABA in the body, but it actually doesn't seem to have an effect on GABA receptors directly. It may inhibit the breakdown of GABA. It also appears to have some effects on voltage-gated ion channels, so we don't really know how it works, but it does seem to have some effects, and it may indirectly affect GABA in the body. Side effects, some GI stuff, nausea and vomiting, you might get some weight gain or some anorexia. The typical central nervous system effects could cause a little bit of sedation, not as bad as the other ones. There is some hepatotoxicity associated with it that's significant, and there may be some hormonal disturbances with it. Again, something you don't want to take during pregnancy. Gabapentin, again, structurally here you can see where the GABA molecule is, and Gabapentin is a drug that's commonly used for epilepsy, but I've seen patients taking it for migraines prophylactically. Oddly enough, it's sometimes used for hot flashes in women who can't take HRT. So women with breast cancer, they've used it for that. It's also used for neuropathic pain. So I've seen people who, for example, HIV patients or people who have diabetic neuropathies will sometimes be on gabapentin. We don't know what the precise mechanism is, but again, this one does not bind directly to GABA receptors. Looking at the structure, I would have assumed that it does, uh, but it seems to have some effect on various amino acid transporters in the body. Maybe that's indirectly elevating GABA or doing something, I don't know. Um, doesn't seem to impact the sodium channels. It might inhibit some of the calcium voltage gated channels in the body, so not particularly sure. Side effects, better tolerated, but again, the typical sort of depressant effects on the nervous system. I wouldn't bother remembering the general effects on the nervous system. I would say the two most common side effects you're going to see with any of these anti-epileptic drugs is going to be it's going to dull down the nervous system, and you can kind of deduce what the side effects are. And then you're also probably going to have potentially GI side effects with any drugs. So I wouldn't even worry about. I don't bother memorizing those. There's a few special things you should look at if it's unique, like a certain nutrient deficiency that it can induce, or the effects on the liver enzymes. I think that's more important. Uh, I don't know why I put this in here. It looks like vitamin B6 deficiency is a possible cause of refractory seizures in adults. So that's kind of interesting. I think I just put that in there thinking that maybe there is some natural treatments for helping with seizures. Maybe giving some B vitamins along with some of this other stuff might be effective for people. Uh, Here's a couple more studies that talk about the effects of vitamin B6 or B vitamins in general and causing deficiencies. So those are the main anti-epileptic drugs that we've covered. I think Dr. Lake will she might cover a few of these things just briefly, just to sort of put the emphasis what you need to know for the exam. But most of the stuff is similar to what you're going to have to read in the textbook. I think the lectures in general that I'm giving is a good background on that, but it might not cover everything that you need to know in the book. So Dr. Lake will sort of talk about that more. Finally, one last little chapter before we end this session, muscle relaxants. There are a couple different muscle relaxants on the market. So Roboxacet, methylcarbamol. This is a drug that's given for muscle spasms and back pain. The main indications is, if you throw your back out or you've got a really bad tight muscle. I don't really know what the precise mechanism is. I can't find that out. I think it must work more on the central nervous system and suppress muscle contractions there rather than targeting the muscles directly. I'll be honest with you, I don't think these drugs are very useful for patients. I think what's far more effective is a hot water bottle or a magic bag, of heat application. Maybe throw some acupuncture needles in, some magnesium glycinate or magnesium citrate, and do some gentle stretching and activity, and that usually resolves the problem. These drugs I don't find very useful. They can be a little bit hard on the liver. They can cause drowsiness and dizziness, but are generally well tolerated. They will potentiate and potentially interact with other sedatives, including things like Kava or valerian, to make you a little bit extra sleepy. But that's about all we know on them. I've tried them before because I threw my back out, and they didn't do anything. Magnesium, heat, and acupuncture is far superior. I think probably magnesium and a hot water bottle is one of the best, most useful tools we can use. So this is another drug, cyclobenzaprine. It's used for muscle pain, also for fibromyalgia and insomnia as an off-label indication. We don't know what the exact mechanism is. It has a similar structure to the tricyclic antidepressants that we're going to talk about in the next set of lectures. So there's some effects on serotonin and acetylcholine in the body. The main adverse effects is the drowsiness and dry mouth, which is more of an anticholinergic effect. Lots of interactions with other drugs, anticholinergics, MAO inhibitors, certain antihistamines, CNS depressants, and anti-epileptic drugs, alcohol. Beyond that, I don't really care too much about those. So that's it for this week, guys. Next week, we're going to complete the nervous system. We're going to work more on the monoamine and the catecholamines. We're going to cover antidepressants, drug used to treat Parkinson's. We're also going to talk about antipsychotic medications, mood stabilizing medications, and I think that's about it. So you guys have a great whatever week, and you will watch this whenever you want to. Okay? Okay, take care for now. Bye.